Good morning, everyone, and welcome to today's webinar, Fertility Preservation, Social and Medical Indications, featuring Dr. Emelia Bachman from Delaware Institute for Reproductive Medicine. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Emelia Bachman is a board-certified reproductive endocrinologist at Delaware Institute for Reproductive Medicine. She graduated from the Johns Hopkins University with a BA in chemistry. She received her medical degree from the Weill Medical College of Cornell University. She completed her residency in obstetrics and gynecology at the University of Maryland and the University of Pennsylvania. She completed her fellowship at the University of Pennsylvania in 2013. Dr. Bachman has practiced as a reproductive endocrinologist and director of fertility preservation since 2013. She was awarded Delaware Today Top Doctor in 2018 and 2019. She is a fellow of the American College of Obstetrics and Gynecology and a member of the American Society for Reproductive Medicine. Dr. Bachman specializes in all areas of reproductive endocrinology. We encourage you to submit questions to Dr. Bachman using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. All right, we're going to get started, and I'm going to pass it over to Dr. Bachman.
Thank you, Alyssa. That was really kind. Thank you all so much for joining me in your busy day. I'm very happy to talk to you about a topic that's really near and dear to my heart, and welcome any questions at the end. So thank you so much. So we're going to start. Alyssa, can I have the mouse? Do you mind? Thanks. Good. So I have no disclosures. And our objectives are to discuss both medical and planned indications for fertility preservation and to describe the available methods for fertility preservation. So, sorry about that. Great. So as we know, women are born with all the eggs they're ever going to have. And so a really important component of the female fertility story is this oocyte pool that we're born with. And this graph shows how the pool is expected to change with the x-axis, which represents time, and the y-axis is the number of follicles or eggs. So we actually have the most eggs when we're in our mother's uterus at 20 weeks gestation. And then from the time of about 20 weeks to birth, they decline very rapidly to about 1 million, roughly. And then the process of follicular vitresia is ongoing even at that stage. And at puberty, we have roughly 300,000 to 400,000 eggs, and that number slowly decreases over time until menopause or the final menstrual period. So this oocyte pool definitely could likely have many genetic, environmental factors, but it can also be altered iatrogenically with certain types of chemotherapy or radiation directed at the pelvis. We know that in patients who go through systemic chemotherapy and in pelvic radiation, the decline in fertility begins earlier and the rate of decline can be faster. And so independent of these causes is unfortunately time. So age is definitely a consideration in this when counseling our patients. So it's important to also see how our fertility declines with age. It's shown in this classic graph looking at over 10 populations, and we see there after 35 and 40, the chance of unassisted conception, really declines. And so, really by 45, it's very rare to have a conception using one's own eggs. So we know that the number of oocytes decreases with age. As I said, this decline is independent of ovulation. So a lot of patients ask me, like, can I go on the birth control pill and save my eggs? The answer is no, unfortunately. I wish we could do that. And we do have ovarian reserve tests to help us determine the number of ovaries and hopefully response to stimulation. And we'll talk about these in a little bit. But it is important to educate patients that the quality of the oocytes decreases with advancing age. So you get increased mitotic spindle abnormalities and then increased aneuploidy in preimplantation embryos. So not only do pregnancy rates decline, but unfortunately miscarriage rates and aneuploidy does increase with time. Excuse me, sorry. So it's important to just look at the HPO axis. These are the important neuronal and hormonal connections that are critical for reproductive function. And so remembering that we start at the level of the hypothalamus, which secretes gonadotropin-releasing hormone, which then acts on the pituitary to release follicle-stimulating hormone and luteinizing hormone in a cyclic and pulsatile fashion. So these in turn act on the ovaries, which contain follicles, right, within which are oocytes. And it is the gonadotropin inputs that allow for an oocyte to mature into a gamete competent to achieve a pregnancy. So additionally, the ovary produces estradiol and progesterone, the balance of which changes throughout the menstrual cycle, critical to creating a receptive environment in the uterine endometrium. So most fertility preservation options involve manipulating these pathways in some way or the other to preserve endogenous function or to bypass the need for an intact axis in the future. I apologize for this. So how do we assess fertility? I think it's really important to know that the age is the primary predictor for pregnancy. So while we have these tests to tell us about the ovarian pool that's left, these are really surrogate markers for this. And we do know patients who have low egg reserve who may still conceive, and patients who have, quote, who have very high egg reserve who may not conceive. Again, we're looking at the age is the primary predictor, and that, you know, there really is no other good quality test. We do have lab tests like the day 3 FSH and estradiol. These are looking in the early follicular phase. They are most accurate, and that's day 2, 3, or 4. And you want to get both an FSH and an estradiol because you need the estradiol to evaluate your FSH, because estradiol will suppress FSH. So if estradiol is high, it actually means your FSH is really higher. So I see a lot of, you know, when I get some records from outside places, sometimes I see only an FSH, and we really want to get both of those to be able to interpret. We also have a blood test, the anti-Mullerian hormone. This is cycle independent, and this is released by the granulosa cells of the follicles, kind of giving us a sense of the basket of eggs. Again, AMH does not predict whether or not someone will have a baby. Age does, but it may predict response to treatment, and we'll see subsequently how we can maybe counsel patients on how perhaps they may respond to these treatments. We can also do an ultrasound and do what's called an antral follicle count. Again, this is typically done early in the cycle in the follicular phase, and you're looking at those small follicles that are between 2 to 10 millimeters. And this looks another surrogate marker for the egg reserve. So getting into oocyte cryopreservation, in 1986, the first reported live birth from a cryopreserved egg was reported. But really, you didn't see this gain traction until about the 2000s, where egg preservation was more widely used. And initially, we were only doing this for patients facing gonadotoxic therapy. And so over the time, the techniques and success rates really have improved. And we switched from a slow freeze method to vitrification. And now vitrification, or this faster freeze, is the standard for oocyte cryopreservation. And in 2012, ASRM put out a statement that oocyte cryopreservation is no longer experimental. And so this is a nice schematic about, you know, the slow freezing. So the slow freezing was kind of a programmed, you know, lower concentration of cryoprotectant, and the eggs were slowly cooled in a programmable freezer. Whereas in vitrification, we have a high initial concentration of cryoprotectant, and there's an ultra rapid cooling. And so what's really important is the oocyte has a lot of water content in it, is really susceptible to damage. And so they're basically trying to solidify the cell into a glass-like state without ice formation. So really trying to limit those ice crystals. And so this has really been shown now. This is our standard of preserving embryos, oocytes, and ovarian tissue. And here again, we have in 2012, ASRM had declared that oocyte cryopreservation should no longer be considered experimental, and it was recommended for patients with appropriate counseling, which we'll talk about. So what are indications for fertility preservation? As we know, gonadotoxic medical therapy, such as malignancies, rheumatological diseases, hematological diseases, radiation therapy, gender-affirming hormonal or surgical therapy, and also planned oocyte or embryo cryopreservation. Patients who either delaying childbearing for any reasons, or any medically complex patients who need use of a gestational carrier as well. I'll first talk about cancer patients, and it is important to be aware, actually, of the ASCO guideline, and this actually was first put out in 2006. It was then reaffirmed in both 2013 and 2018. And so it's important to be aware of this. This is going to be, it's important that patients, as part of their informed consent prior to therapy, oncologists or any other medical providers involved in a patient's care should address the possibility of infertility with patients as early in treatment planning as possible. And this is really important because for many patients, they may not have known of these options. And often, in many situations, we do have time to do this. I think, I've heard this from both patients and physicians or other providers through the years, the cancer is so aggressive, or the prognosis is so poor, but it's important that we at least have the conversation with our patients to allow them to have the autonomy to make that decision. And really, we're seeing more and more, I'm seeing more and more consults and referrals for patients. So it really, over the years, we're really getting, the education is out, and also patients are more aware. So we're really being able to talk to many patients. So what are different fertility preservation techniques? I'll talk about this. We can freeze mature eggs. We can freeze embryos. We can freeze ovarian tissue. And we can also perform in vitro maturation. We'll talk about that. So in 2018, there were over 800,000 cases of new cancer in females among premenopausal women. So there's an 11% probability of cancer diagnosis in premenopausal women. And we see that the overall cancer death rate has really decreased over time. A third of these are associated with breast cancer, and there are also the malignancies which affect younger women with survival rates greater than 80% are lymphoma, leukemia, breast cancer, cervical cancer. So we see the survival is really high, which is great, right? But we see that, in some studies, about 40% of survivors do not recall discussing fertility impact of cancer treatment with their oncologist. And 24% of male cancer patients only pursued sperm banking, and only 4% of young female cancer patients pursued fertility preservation. So I think this number is a little bit higher. It was hard. I was finding ranges of things, and we're seeing more and more patients, but it's really important to see that patients are not having this discussion. And the most important thing is to have the discussion with the patients so that they can make the best decision for themselves. And we're seeing that many younger patients are surviving, as I said, and the treatment is really detrimental to both male and female reproduction. And there are studies that show the loss of fertility really negatively affects the quality of life in young survivors. And over 3/4 of patients are interested in the opportunity to have children after their cancer diagnosis. And there are studies that show that one of the biggest sources of depression and anxiety later on is that loss of the ability to have a biological child. But what studies also have shown is if patients had discussed this with their providers and were able to make that decision, even if they did not pursue fertility preservation, that they still felt better about that decision. And that's where I take this away. When I see my patients, I tell them that I am not here to convince you to do something. I want you to be educated about what is happening, what are the risks to your future fertility, and I want you to be able to make the best decision for yourself. And I've had many patients who don't pursue, but they are appreciative of the conversation and just having that information and knowing that they were able to make that decision for themselves. On the other hand, there are many patients who do pursue, or they know they want to, they know they always wanted to have a biological child, and they're very grateful for that opportunity, and it may be one thing that they can control in this really stressful process. So what is the impact of cancer treatment on reproductive function? It's important to know while we stratify certain treatments as high, moderate, or low risk, it's important to counsel patients that we cannot guarantee return of fertility after any type of treatment. Certainly our highest risks are the alkylating chemotherapies, also total body radiation and stem cell transplant, and there are much lower risks where some patients may decide not to pursue, but it is important to know that we can't guarantee any patient return to fertility. It's also important to talk about hormonal treatments as well. So some patients, such as in breast cancer with estrogen receptor positive tumors, they may be on letrozole or Lupron or tamoxifen for many years. And it is recommended that they not try to conceive during that time. And this can be 5 to 10 years. So while these are not directly gonatotoxic, that time to complete the treatment may affect their chances of future fertility due to ovarian aging. And so that's an important population to also talk to, even though they may not, maybe they're having surgery and local radiation to the breast and having hormonal treatment. If they're 30 and then they're not going to be 40 until the time it's finished, that's still going to be an effect on their future fertility. So they may still want to cryopreserve oocytes or embryos. Oh, I apologize. Great. So the study by Dr. Gracia at Penn, they have shown that survivors who received chemotherapy already have diminished ovarian reserve. And so you see that patients who are exposed, their ovarian reserve parameters are lower to those patients that are unexposed, and this is statistically significant. And these associations persist even if women are menstruating. This is also another important point to make. So we see here that the loss of oocytes is faster for survivors. So even if their fertility returns, they have return of menses after treatment, they still have some egg reserve. This natural decline in egg reserve, the slope will decrease and much steeper for patients who've received gonatotoxic therapy. Aside from the treatment itself, the age at the time of treatment was also highly associated with the return of menstrual function. So almost 90% of women less than 35 regained their monthly menses after 6 months, while only 20% of women, at least 40 years of age began menstruating. And this suggests that, the older you are, it's the less likely that menstrual function will return after chemotherapy. As I touched on, normal menses does not equal normal fertility. So we know that they're not equivalent. So someone can have regular menstrual cycles and still not be able to conceive. And there was a nice retrospective study of over 1,000 women in the California Cancer Registry. And they found that a large proportion of cancer survivors reported difficulty conceiving even though their periods had returned. And so the blue line shows the breast cancer risk, and you can see the infertility increases with the risk at diagnosis. And so you can see the younger you are, you have a higher chance of returning to fertility versus the older you are, it's a much lower chance. So I'm going to talk about some other treatments first before getting into oocyte and embryo cryopreservation. There are treatments that, one of the thoughts is, can we avoid even putting patients through these stimulation cycles and having to freeze their eggs? Can we protect their ovaries and protect their eggs during the time of chemotherapy? And so there have been several studies on GnRH-Analog Treatments, and that involves administration of injectable GnRH agonists prior to and during the gonatotoxic therapy to preserve ovarian function. This is an off-label use for that. And the thought is to make the ovaries quiescent to decrease their ovarian activity, and that maybe reduce the damage to the pool of immature oocytes. And some randomized controlled trials have shown mixed results. The meta-analysis in patients with Hodgkin lymphoma showed no benefit. And while there's a meta-analysis of patients with breast cancer that showed a significant reduction in premature ovarian insufficiency and a higher number of pregnancy events after chemo. However, the pregnancy data was not uniformly reported, so the data is limited. But the mechanism is not fully understood, but we are thinking that some primordial follicles may not be affected if the ovary is kept quiescent. And so we also want to make sure that we're not interfering with cancer treatment as well. But there are data demonstrating that a reduced risk of recurrence and death in breast cancer patients that were treated with GnRH agonists. Certainly, I think so far, I think patients need to be, counseled that it's an experimental off-label use, but the risks are low. We use these widely for patients with endometriosis, fibroids, pelvic pain. We use it for IVF cycles. So, we see that the safety profile is there. It does put patients into a medical menopause, and the thought is it can protect the ovaries. Certainly, I think sometimes it may be worth trying. And this is, again, one of the studies in breast cancer patients which showed reduced rates of ovarian failure, 8% versus 22%, and improved disease-free survival. So again, they're experimental. It remains controversial, but it may be beneficial to breast cancer patients. But it also may be critical for some patients who may have chemotherapy-induced thrombocytopenia to prevent heavy menstrual bleeding. But it really shouldn't be used in place of other fertility preservation options. So often I offer it to patients as an adjunct. I've had many patients who have said they weren't ready to go through stimulation and they at least wanted to try it, but they were counseled about this. Okay. Another alternative is ovarian tissue cryopreservation. This process involves a laparoscopy in which ovarian cortical tissue is removed, divided into small strips, and frozen. So the oocytes retrieved are immature, so they would require in vitro maturation for utilization in IVF, or retransplant into the patient. This is done as an outpatient surgical procedure, and as of 2019 is no longer considered experimental. It's important to know, though, it really should be considered if time does not allow for ovarian stimulation, patients who are prepubertal, or maybe some patients after the initiation of chemotherapy. The benefits are there's no ovarian stimulation, there's minimal delay in treatment, no partner is needed, but it really is the only option in prepubertal girls. It is important to note, though, that there are only about over 200 live births worldwide. And if someone can freeze eggs or embryos, that is the better choice. These are pictures from a case at Penn. The picture in the upper left shows the initial laparoscopy with dissection of the ovarian cortical tissue with endoscopic scissors, and that's passed off the field and cut into 1 centimeter strips and then frozen. And then this patient came back to utilize the tissue and underwent a second laparoscopy in which the tissue was thawed and sutured to existing ovarian tissue. And she did have resumption of her menstrual cycle. So orthotopic transplantation is usually most successful, usually to the contralateral ovary or the ovarian fossa, and can restore ovarian hormonal function with an average time to menses of about almost 5 months and duration of function anywhere from 9 months to several years. There are concerns about reintroduction of malignant cells in the setting of leukemia or tumors that have ovarian involvement. And it is possible to test tissue for tumor cells by RT-PCR for certain tumor types. To date, again, like I said, there's over 200 live births worldwide. But what is important to know is that we don't have live births from in vitro maturation of these eggs from tissue in the lab. So in the lab, we have in the human, as far as a mature egg, there are no live births from that. So all the live births reported are retransplanting this tissue into the patient. And again, if you're worried about reseeding. Now, I have seen some studies where maybe people thought that was a very low risk, but again, something to consider for the patient. So this is very experimental. So the question is, can we immature eggs from tissue be matured in vitro? And the advantages would be eliminating the risk of transplanting cancer, precancerous cells, eliminating the need for surgical transplantation. But unfortunately, this is a complicated process that is poorly understood, and there are no primate or human births to date that's successful in the mouse. There also is another technique, it's called in vitro maturation of immature oocytes. And so can we retrieve these immature oocytes from the unstimulated ovary, or maybe very minimal stimulation, really causing less hyperestrogenism, less cost, lower risk of ovarian hyperstimulation. But there really is a lower success rate overall, and you really have to be in a lab that actually has some experience with this. This is not really widely performed. So going to what our most standard options are both gamete and embryo cryopreservation. So sperm, oocyte, and embryo freezing are the most likely strategies to yield for future pregnancies. And the discussion and referral should be made at the earliest opportunity, as we discussed, to allow adequate time and options to complete more than one cycle. This requires a 2 to 3 week window for ovarian stimulation and oocyte retrieval for women freezing eggs or embryos. And again, I did mention sperm, but this talk is mostly focused on female preservation. So oocyte and embryo banking procedures should be completed. It's most effective prior to the initiation of cancer chemotherapies. Previous chemotherapy is likely to decrease the number of retrievable eggs, but in certain patients who may not have had the choice or may not have known about the option, sometimes we can counsel them if they've had some chemotherapy in the past. If attempted within 2 to 3 months of exposure to the chemo, there is a risk of no eggs being retrieved. And so there's concerns that the follicles recently exposed to chemotherapy may also yield abnormal oocytes, and these are in animal studies. So what are the goals of oocyte and embryo cryopreservation? So we want to avoid the delay of cancer treatment. We want to maximize the yield of oocytes. We want to minimize the risk of ovarian hyperstimulation syndrome. For those of you who may not know what that is when patients are given gonadotropins to stimulate eggs, and they may have a really robust response, which on one hand would be nice to get a good yield of eggs, but we also don't want the patient to get sick, particularly someone who has cancer. So you can get ascites, third spacing of fluid, at worst can get a blood clot. So we really are careful about this and careful about dosing. We want to optimize safety with respect to the medical risks and comorbidities of the patient. So things with like estrogen-sensitive tumors, we may use letrozole protocols to lower the estrogen risks. For anemia and thrombocytopenia, patients who have that coordination of transfusions, patients who are hypercoagulable, maybe adding, using an anticoagulant during the stimulation. Typically, we stop it approximately 24 hours before the egg retrieval. Sickle cell patients are unique in that we do have to make sure they are also have anticoagulation, they are appropriately hydrated, so they can have plasma cell exchange apheresis during the time. So typically, and many of these patients who have complex medical cases, I'm working directly with the oncologist, together to make sure the patient is safe during the time, and counseling with them about how, what's happening with the cycle, what are the risks to the patient, and we're working together to try to make this as safe as possible. For many, if anyone has ever gone through IVF, most of the time that we start with either the beginning of the period or with a birth control pill. With cancer patients, we don't have that time necessarily, or we don't want to put them on a birth control pill. We can do a random start. We can immediately initiate ovarian stimulation regardless of the phase of the menstrual cycle. And we typically do get good results. Some times of the cycle aren't as optimal as others, but again, if the patient doesn't have much time, we're able to do this without waiting for the next cycle. We usually use these GnRH antagonist-based stimulation protocols. The reason for this is to prevent the hyperstimulation, where we can use a lupron trigger, which has been shown to prevent hyperstimulation. We can also use, like I said, anti-estrogens during stimulation for breast cancer patients. A lot of patients ask me, like, is this safe for me? A lot of oncologists ask, is this safe? We're giving them hormones for 2 weeks, and follow-up data showed that there was no difference in relapse-free survival in breast cancer patients who underwent stimulation compared to those who did not. And for many patients, they're not undergoing chemotherapy right away. They're having, PET scans scheduled, port placements. A lot of times we have a few weeks. And usually, again, what I do when I meet the patient, I contact the oncologist. We talk about the treatment plan. We talk about the type of treatment that needs to be given to the patient, the timing of this treatment, and then again talk with the patient again about these factors and decide whether it is safe for the patient. And then, of course, we always want to respect the patient's wishes and what they want to do. Patients are really overwhelmed with their recent diagnosis and impending treatment. Fertility is a really emotionally charged issue, and they may not be familiar with fertility treatments. And so there was a study in 27 breast cancer patients that about, almost 40% of them had difficulty making a decision. Insufficient time was a common complaint, and most wanted to meet with a psychosocial counselor. Decision aids like educational pamphlets can help. Typically, what I do with my patients when I see them, again, I'm very open with them and saying, I want to help you with this decision. This is your body. We want to make sure that you're doing the best decision for, for your goals of your, future family. And we do offer, discussion with the therapist. I usually follow up with them after the visit as well. It's usually not, they can't make a decision right there. There are some patients who come to me and they know they wanted to do it and they were the ones who brought it up, but some people need some time, and unfortunately we don't have much time. But typically I like to follow up with them and, just provide my direct contact information so that, in this really critical time that's really emotionally charged, that they're able to, ask more questions, because that first visit can be really overwhelming. Sorry. So how do we make these decisions? We want to look at their health status, their age, pubertal status, ovarian function, what fertility preservation options are available to them. Unfortunately, cost is a big issue too. There are certain groups like Live Strong and Heartbeat Program and Reunite that give assistance with medications. Different practices do different things. In our practice, we do offer reduced cost to our cancer patients. Many insurances are covering this more and more, but we have a long way to go there. And also we want to discuss social and ethical considerations of the patient. What are their wishes? What is their wish for their future family? And that's one thing I always talk about. What's your dream of your family? And is it to definitely use your eggs, or do you consider other fertility options as equivalent, right? And for different patients, that may mean something different. So it's really important to have that open conversation with them. I think a multidisciplinary approach is key. I think it's really key to be in contact with the oncologist and in contact, if they need to talk to someone, it's important for them to be able to do that. Okay. So another population that is really important to consider fertility preservation are, for transgender adults who desire future parenthood. So many of these patients desire future parenthood, and several studies have suggested that having genetically related children is an important consideration. For trans men receiving testosterone therapy, ovulation is often suppressed, and for many, conceiving and carrying may not be desired. So trans men may consider oocyte or embryo cryopreservation prior to initiating testosterone therapy. I think testosterone in the short term will not necessarily affect the eggs. Long-term treatment really will suppress the ovaries. And so it's important to, and we don't really have, studies on really long-term studies on this. So we don't have studies on the health of offspring conceived from testosterone-exposed oocytes. And the effect of the gender-affirming hormone therapy on fertility and the reversibility of these effects is currently unknown. So we could have a whole presentation on this, which is it's also really dear to my heart. So I think it's important that these patients are offered fertility preservation. We have offered for patients who've even already gone on hormonal therapy, stopping that hormonal therapy for about 3 months. Again, for some patients, they don't want to do that, right? So it is really important to at least have that conversation beforehand, because once they start the gender-affirming hormone therapy, they may feel really good. They're going to feel really good, and they may not want to come off of that. There are some small studies looking at continuing the testosterone. We do have some studies in women who have low egg reserve who use testosterone as a kind of an adjunct. Again, there aren't good, data on improved live birth. So we know people can take it before IVF cycles, but again, having that high dose testosterone for such a long time, the ovaries will not respond well. So it's important to think about that beforehand. So it's important that transgender individuals should be offered fertility preservation prior to starting gender-affirming therapy, because both of the current lack of knowledge on fertility following hormone therapy and to possibly prevent reoccurrence of gender dysphoria following transition. Considering for trans men, we should consider oocyte embryo cryopreservation prior to initiating testosterone therapy. If they already are on, consider a 3-month cessation of the therapy for fertility preservation. So now I'd like to talk about intended or planned oocyte cryopreservation. I was actually chuckling as I was making my slides. I apologize, I wasn't paying attention to my talk is medical and social indications. We actually do not want to use the word social anymore. Social or elective maybe implies that they're doing this for fun or chose to do it. And the reality is, for the majority of women, they have not. This is not the case. Many of them do not want to be in this situation. They've wanted to be with a partner or have children earlier. Again, everyone is different, right? But for many patients, this is not something that they like doing. It is intended to enhance a woman's reproductive autonomy. Again, we talked about in 2012 that we did not consider this experimental. And currently, oocyte banking comprises about 5% of all IVF cycles. So when you look at reasons for women deciding to freeze eggs, the most common reason cited is lack of a current partner. And you're hearing this all over the place, like, oh, it's her job, it's her education. And they're also on the list, but lack of a current partner is the most common reason. And this is a study from NYU from 2005 to 2011, about 478 women who went through one or more oocyte cryo cycles, and the reasons that they went through. So to go back, you may have remembered these articles. So shortly after the experimental label was lifted, an article chronicling one woman's decisions about egg freezing made the front page of the Bloomberg Business Week. This intelligent, accomplished woman went on record for advocating egg freezing as the way to have it all, and she was in her late 30s. But fast forward to January 2018, the same incredibly brave woman was interviewed by the Washington Post and Wall Street Journal in follow-up pieces. And we saw the harsh reality of her journey through this decision to thaw eggs on her own at the age of 45. And the shock that realizing what she thought was a foolproof insurance policy did not come through. And ultimately finding her way to her goals through the use of an egg donor. This is one of many situations that highlight the nuances of managing patients who desire oocyte cryopreservation. And just in her egg cycle, it was roughly 11 oocytes that were cryopreserved in her late 30s. 9 survived the thaw, 6 fertilized normally. These are all great numbers, right? And 1 embryo out of those 6 was chromosomally normal, also not an unreasonable number for the late 30s. And with each normal embryo, we know it's a roughly 60% chance of pregnancy, and she did not have a live birth, unfortunately, which is very sad. So I think, to me, it's important when I counsel my patients to say, unfortunately, this is not a guarantee. I think it's important to offer this to all women. I think it's important to educate women about their fertility and about their egg reserve. Again, knowing that egg reserve does not predict future fertility, it does not predict live birth, but again, it's one marker that we have. And it's important to talk to women about their goals of their family. But they should know that, unfortunately, this is not 100% guarantee. How I like to talk about this is in probability, where, if I have 10 eggs from 35, I'm much happier with 10 eggs at 35 than I am at 40 years old. So it can increase the probability that we'll have a live birth. We can't guarantee a live birth. And so recognizing that oocyte cryopreservation was becoming increasingly widespread, ASRM published an updated guideline to provide some guidance on the available data. So they do say there's insufficient evidence to recommend to counsel women about the likelihood of live birth after planned oocyte cryo. I will show you some data on, some probabilities and numbers that we show patients, but we don't know how to tell them exactly. There isn't an exact number for each person. And on the basis of limited data and ongoing and live birth rates appear to be higher for women who've planned oocyte cryo at a younger age versus older ages. We do see that neonatal outcomes appear similar with cryopreserved oocytes as compared to cryopreserved embryos, but we do need more long-term data. So here's what do we know about egg freezing and what is the likelihood that this process is going to work? The reality is, unfortunately, we're using extrapolated data to counsel patients. And this table has data from 4 randomized controlled trials that primarily looked at success rates between fresh oocytes and frozen oocytes. While they do show relatively comparable pregnancy rates between women using fresh and frozen eggs, you're seeing here that the clinical pregnancy rate per oocyte thawed is very low. I think this 12 is quite high. For most studies, you're looking at a 4 to 6% chance per egg. And I've definitely heard that from patients like, but doctor, all I need is 1 egg. And I say, I know, and we've all had the miracle story, but we really need a group of eggs. And we need, because each egg on its own is not a high chance for live birth. So, they're also looking at, there's some more data looking at, what is the success of the elective egg banking, and the IVI group also published on their success with elective egg banking, and they found that cycles from over almost 1,500 women who froze their eggs, 9% returned to use them about 2 years later. So that's another important point, is that we don't have as many women coming back to use the eggs. I think we're seeing this more and more, so we're going to be getting this data over time, right? So the take-home message here is, the live birth rate at 35 and younger is going to be much higher than 36 and older. So if you look here, 10 eggs at 35 and younger is a 60% chance of a live birth versus 10 eggs at 36 and over is half that, about 30% chance. And that's really important, an important piece to counsel patients on. Again, I think some patients, they weren't ready to do this before. They didn't think they had to do this. Maybe they got divorced. And so it's still important to counsel these patients that, we want to do, what will make you feel better, and we want you to try to achieve your goals. But I do counsel patients over 40 that it's a very low chance for success, unfortunately. How many eggs are enough? And this is a common question that arises. And this is a challenging conversation. Again, as we're saying, the outcome data are limited. But this is a study published in Human Reproduction by investigators at the Brigham. And they wanted to model the chances of live birth by these important criteria: the age and the number of eggs retrieved. And so this graph shows the probability of having a live birth by the number of mature oocytes retrieved and stratified by age. So as you can see, in a woman under 35, if you get 10 eggs, you have about a 75 to 80% chance of live birth. At the age of 38, the same number has about a 45% chance, and at the age of 42, 20%. Now this is assuming a comparable egg yield at different ages, and again, we know that different patients, we can't test for quality either. So we have many patients who have good egg reserve parameters, but the quality of the eggs. We also see that there's some patients whose eggs just don't freeze well, and you won't know that until the end. And again, I counsel my patients very frankly about this. So what if you want a sibling, right? So this is a great study from Doyle and colleagues who looked at 117 women who returned to use their eggs. And there was a 39% live birth rate per transfer and a 6% live birth rate per frozen egg. And so they modeled the probability of having 1, 2, or 3 children by the number of eggs thaw. And as you see, and as you can probably predict, the success decreases by age. So if you look at just kind of general numbers, the authors are recommending roughly 13, 14 eggs in a 30 to 34 year age group, about 15 eggs in the 35 to 37 group, and 26 eggs in the 38 to 40 year group. If you look here in the 41 to 42, they're not even with 30 eggs, they're not getting to a 50% chance. So unfortunately, eggs are they're more fragile, they're more aneuploid at this age. Again, for the right patient, this might be her goal and what she may want to do, but they do need to be counseled. And I do show my patients this data and talk them through that. So when is it best to freeze my eggs? Like, this is a really important question. Should we be, scaring every 20-year-old into freezing her eggs in her early 20s? I don't think so. I think it's important for women to be educated about the natural decline in fertility and educated about their options so that they can make the best decision for themselves. So if you look at this, this study was done at UNC to address like natural fertility and like when is the benefit the best. So on this chart, the x-axis is the age at which the woman decides to freeze or not freeze her eggs. On the y-axis, we present the subsequent probability of a live birth 7 years later. So the blue line shows the live birth rate by age among women who decide to freeze their eggs, and the red line is the live birth rate among women who do not freeze their eggs. So your highest live birth rates for women freezing eggs are observed between 25 and 30. But in this, if you look in this age group, the difference between natural fertility and pregnancy after assisted reproductive technologies is actually minimal. So suggesting that at this age, it may have minimal benefit if the eggs are used within 7 years, because then you could potentially just do your own IVF cycle, in that time frame, right? In the early 30s, the difference becomes greater. So at age 32, there was a 12.5% difference, in live birth rates between those who froze and those who didn't. But if you chose to freeze at 37, you had a 50% chance of having a live birth, whereas if you didn't, your chance would be 20%. So that may be a little high for that natural fecundity at that age, but like, it's just the bottom line is it's the early to mid 30s is probably best for yield and to decrease the risks for aneuploidy. So there was also a study out of Boston IVF looking at oocyte cryopreservation. And in this study, 7.4% of patients have returned to use their previously cryopreserved eggs. The clinical pregnancy rate per embryo transfer was about 47.5%. And there wasn't a difference less than age 38 and between ages 38 to 40. It is important to note, though, there was no live birth. There was an N of 6 of patients over 40. There were no live birth from oocytes cryopreserved at age greater than 40. Remember, some patients may be using this over 40, but we're talking about the age in which these were frozen, right? We know the uterus doesn't age, and that's the whole reason we're doing this. Another study, recent study out of NYU, which also, looked at patients coming back to use eggs, since we're lacking data on women returning to use the eggs. So they wanted to study the group of women who should have used or most likely used their eggs. And so there was a 10 to 15 year follow-up. It was a retrospective cohort study, and these patients did at least one cycle of planned oocyte cryo between 2005 and 2009. And so this was 231 patients with 280 cycles. The mean age at the retrieval was 38, with the range of the patients freezing with 23 to 45. And there was an average of 10 mature eggs per retrieval, cryopreserved. 88 patients had returned. 38% have been warmed to make embryos. And the mean age at the warming was almost 44. And 60 of these patients had at least one embryo transfer, and the live birth rate was 34%. If you wanted about the others, there was 47% of the patients still had the eggs in storage, 11% discarded, and 3% transferred to a different clinic. The mean age of discarding the eggs was 47. And they also noted that 8 patients had normal embryos but have not transferred them yet. Unfortunately, in that group that did warm, 20 had nothing to transfer, where either the embryos arrested or they were genetically abnormal. So it is important also to counsel patients that embryo cryopreservation is an established technique along with egg freezing, but embryo has been available for a lot more years, and we have much higher success rates. But what is the problem? The problem is it requires a committed partner or the use of donor sperm, right? And for some patients, those are not options, right? They may not have a current partner, or they may not want to use donor sperm at that time. For patients who do, maybe patients who are in a same-sex relationship and would be using donor sperm, or maybe they feel like, I don't know if I'm going to find someone, but I want a better chance. I may just get some donor sperm because I just want to be a mom. I've had patients look at me and they say, I don't really care anymore. I just want to be a mom. And for those patients, I say, we may want to freeze embryos because we just have much better success with that. And this is just looking at the 2019 national SART data with, you just have much higher live births with embryo. Now, again, I want to say once we get to the embryo, the success of pregnancy is going to be the same, whether or not you come from a frozen egg or a fresh fertilized egg. But you may need more eggs because some eggs may not survive that thaw. They may not develop. Some people's eggs may not freeze well. So, but once you get to that embryo, you're still going to have that same chance as when it was cryopreserved. And I think the benefit of the egg freezing is if someone does not have a partner or they're not really in a committed relationship. I'm sure you've heard a lot, the news stories about these, cases of, lawsuits over embryos. If two people make an embryo, both partners have to consent to making a child. And so that can become very, very challenging in the future. So I do tell patients if this is not a committed relationship and you're not sure, you do want to freeze your eggs to have that freedom of choice in the future. So there's a lot of benefits to freezing eggs or embryos because some patients may need a gestational carrier in the future if they've had, toxicity from cancer therapy, or if it's deemed that they're going to have a high recurrence rate after hysterectomy. And also pre-implantation genetic testing may be an option for patients who want to test those embryos. Again, it's not perfect, but it's about 98 to 99% accurate, or patients who may have a genetic mutation. This is another graph I like to show people. Percentage of abnormal embryos increases with age. So we see even in egg donors, even young, healthy women in their 20s, you have about a 30% aneuploidy or abnormal rate. This does increase over age. And so this is where I counsel a lot of my patients over 40, that number that, 70 to 90% of the embryos can be abnormal at that age. And just looking at, why pregnancy hasn't occurred, why miscarriage rates are so high, and why these cycles sometimes are not successful. So just to review ovarian stimulation for you. And I always talk to my patients about, I liken this to the natural cycle. Often we do put patients on some sort of pre-stimulation treatment like a birth control pill or Lupron. We may just start with their period. And again, with cancer patients, we do random starts for time sensitivity. But basically, they're taking 9 to 14 days of daily injections of FSH. And so what I tell patients is, remember, at the beginning of your cycle, you have a new cohort of eggs, of follicles. And in your natural cycle, one of those is chosen and the rest die. But in IVF, what we're doing is we're giving you higher doses of FSH, the same hormone that comes from your brain. And they're taking FSH injections daily for about 9 to 14 days. And then we also add a medication like a GnRH antagonist to prevent ovulation. So once we get a good cohort of mature follicles, then we trigger ovulation with either HCG or Lupron, which they both work on the LH receptor, and then schedule egg retrieval roughly 35 to 36 hours later. This is just a picture of the ultrasound-guided oocyte retrieval. We usually use a transvaginal probe, which has a needle guide. Basically, you're just going directly, you just gently puncture the vaginal wall, and you can gently move around the ovary. We can do abdominal retrieval for patients who have cervical cancer masses. So we can do that as well, although the yield is not as good as in the vaginal, but it is possible. Great. So what happens? We obtain those eggs, we evaluate those eggs for maturity, and then they can either be cryopreserved right away at that point or inseminated with sperm-to-form embryos. If the fertilization is successful, then we monitor these embryos for 5 to 7 days in the lab. And then there is the option of the embryos for pre-implantation genetic testing for genetic disorders. This is just a picture of embryo development. I know I'm running out of time. I'm sorry. This is a mature egg. This is a fertilized embryo. You see the 2PN, the 2 pronuclei, and then we have mitotic division to then make the blastocyst. So to talk again about pre-implantation genetic testing, we can test these embryos for genetic abnormality before transfer, allowing the selection of quote unaffected embryos. PGT-M for a monosomic disorder avoids the inheritance of a known genetic disease, maybe someone who carries a known genetic mutation or had a fetus from a previous pregnancy affected. PGT screens for aneuploidy, for just looking at chromosomes. Is this a 46XX or a 46XY? This is more useful in advanced maternal age and recurrent pregnancy loss. And I didn't mention PGT-SR for a structural rearrangement, patients who have balanced translocations. they have recurrent pregnancy loss due to a balance translocation, we can do that. And it's important. Some people don't understand that they can't just do PGTA. So there's actually a structural rearrangement. We need to test for that and make a probe for that. So what are the risks and safety concerns? Basically, we're saying that ovarian hyperstimulation syndrome is less than 5%, but it's basically avoidable with lupron trigger. Ovarian torsion, less than 1%. We tell patients no exercise, no penetrative intercourse, infection bleeding, less than 1%. And really, we're seeing no, for comparing egg freezing, no increased risk of adverse neonatal outcomes compared to IVF, no increased congenital or chromosomal abnormalities when you look at frozen embryos versus frozen eggs. And costs can range somewhere between 7,000 to 15,000 for frozen eggs, and for IVF cycles, somewhere between 10,000 to 20,000. So there's some studies looking at birth outcomes and looking at over 900 oocyte cryopreservation babies born with no apparent increase in congenital abnormalities, which is helpful. Again, we need more data, but the data so far are reassuring. I'm going to go through here because we're running out of time. So again, short-term data are reassuring, but we're lacking long-term data on developmental outcomes and then women from advanced age. So the cost of pursuing the treatment, regardless of the indication, can be a major barrier to accessing services. This was an online survey done at Penn, looking at egg freezing in 1,000 women who either had children or desired childbearing, and they found that overall 25% of women would consider freezing their eggs, but on average, they would be only willing to pay about $3,800 for it. And again, unless they have insurance, this is not the self-pay cost for this, unfortunately. They did say if the total cost were $10,000, 91% of the cohort would accept a minimum 50% live birth rate per cycle to proceed. The implications of the study are that we think the cost should go down. We need to freeze sufficient eggs less than 35 years of age when success is good, and need better insurance coverage for this. What are other parenting options? So I always talk to patients about other parenting options. Again, I tell my patients, look, this is a decision you need to make for yourself. If it would devastate you not to have a biological child in the future, I want you to consider this very strongly. But you should also know that there are options such as adoption, donor egg, and donor embryo. And these have very high success rates. While they can, again, still be unfortunately expensive, donor embryo can be a little less expensive than donor egg, but nonetheless, it's not free. Adoption can be expensive and time consuming. But I've had many patients where these are options that they have pursued and they were very fulfilled and happy. And so it's important to give patients the range of options for family building so that they can make the best decision for themselves. We say, don't be afraid to start the conversation. This begins with the well woman exam, just talking about reproductive counseling. What are your wishes for the future? Counseling on future fertility. It is important for patients who may have had a prior oophorectomy, multiple cystectomies, endometriosis, transgender patients, any genetic disorders. They may want to have a consult about this early, and that might be. And I really encourage people, use the age as your primary biomarker to counsel your patients. And they can come to a reproductive endocrinologist to talk about the process, these options that they have, the process, success rate, costs, risks, and benefits. Again, in my practice, I'm very open with patients. I say, I really want this. This is for you. I'm here for you. And I don't want you to feel there's no pressure from me just to put you through a cycle, because I just don't do that. What I want to know is what are your goals? What are your dreams? And how can I help you achieve that? And what is the best option for you? My conclusions, again, education is key. We have the natural decline of fertility with age. Remember, ovarian reserve does not predict live birth. All patients with a cancer diagnosis should be counseled regarding future fertility as early in their diagnosis as possible. I want patients to explore all options, banking, oocytes, or embryos. Maybe they pursue pregnancy earlier. I've had patients who come talk to me and they're like, you know what, I think I'm just going to try to get pregnant now. And that might not be everyone's choice, right? But it might be right for that individual patient. Donor egg, donor embryo adoption, or some patients defer all options completely. That's important to know. We don't all have to have children, right? That's another misconception in life where, some women decide not to, and that's okay, right? And so it's important to just be able to make that best decision for yourself. Remember that success is better with a younger age and with a higher number of eggs cryopreserved. Again, oocyte cryopreservation and embryo is not a guarantee, but currently the best way to preserve future fertility and can potentially increase the probability that one will achieve a live birth later. And that's all. Thank you.
Thank you, Dr. Bachman. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions through the questions panel in your attendee control panel. The first question is, what is the ideal age to freeze eggs? When do you want to see it? More for like the non-cancer patients?
For the non-cancer patients, yeah. So I think I'll go back to that data. Hopefully that those couple slides kind of address that. I would say, I mean, ideally, probably with the outcomes, maybe probably late 20s, early 30s. But remember, we saw the data where maybe patients in the late 20s might put all this effort into it and might not need it, right? At the same time, I would hate if someone regretted that decision, right? So I would say under 35 is your best time, but I would never discourage a patient who is 38 and appropriately counseled, because maybe we just need to do more cycles and get more eggs, right? So under 35 would be your best bet. Yeah.
And our last question is, besides cancer, are there other patient types that you think would benefit from this, besides like the social indications, like the trying on their own? But there are other patients
well, right, like you said, there's some patients who have like rheumatological or hematological diseases who are still getting like methotrexate or other medications like this. I think it's important to consider them. I've taken care of many sickle cell patients who are on the road to stem cell transplant, and that is a hugely high risk for infertility. I would say over 80% of patients will go into early ovarian failure after whole body radiation with stem cell treatment. And so I see those patients as well, which is, you know, it's just so rewarding. And then again, transgender patients. So there are a lot of, and also there might be patients who have, again, severe medical issues, like they may not be able to get pregnant. Maybe they have like cardiac issues, and, you know, we can, you know, safely get them through a retrieval, but maybe they shouldn't be pregnant, and then they can use a gestational carrier.
Thank you, that was great. Thank you, Dr. Bachman, and thank you everyone for attending today's webinar, Fertility Preservation, Social and Medical Indications. If you have any other questions, please contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you'll receive a survey on the presentation. We would appreciate it if you could complete the survey and provide your feedback to help with other future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Delaware Institute for Reproductive Medicine, and Dr. Bachman, thank you for joining us, and enjoy the rest. Thank you, Dr. Bachman.
Thank you. Thanks so much. Have a great day, everyone.